Hello, I am Dr. Ahilasamy from Chennai. I am going to show a case of septoplasty with bilateral postnasal neurectomy for a case of nasal obstruction due to deviated nasal septum and nasal allergy, that is rhinorrhea and sneezing. This is a young female around 28 years. You see the gross septal deviation, hardly any space on the left side, and right side also there is minimal space, and you can see the medialized unsnate, which we call as double unsnate. First step is packing the nasal cavity with the roller gauze soaked in 4% lignocaine and adrenaline repeatedly on both the sides. Now I am giving the spinal pattern block on the right side. Now we have got a lot of working space because of the repeated packing with 4% lignocaine and adrenaline in the ratio of 1:1. So you have to spend 5 to 10 minutes for repeated packing to get adequate working space to decongest the edematous mucosa. I am giving the block with a solution of 0.5% ropivacaine and adrenaline in 1:50,000 with a 23 gauge spinal needle. Now I am repeating the same on the left side. You can see the middle terminate, septum, inferior terminate, where the middle terminate curves and attaches laterally. You have to give the infiltration just under the mucosa, and you have to get a good blanching. You can see the blanching. Always aspirate and give. Now I am giving the infiltration on either side of the septum for the hydro elevation with the same solution before doing the septoplasty. Now I am using my own design Dr. Ahila's diathermy endoscopic diathermy round knife to make a incision. So there will not be much bleeding while you elevate the septal flap, and the scope doesn't get fogged frequently. But there is a small disadvantage: the incision area heals very slowly, and there will be crusting post-operatively. It will take 1 week or 10 days more to heal. Now I am using a 15 blade to cut through the cartilage so that I can elevate on both sides of the septal cartilage to get the flap. You see hardly any bleeding. One thing is I am using my own Dr. Ahila's diathermy knife. Another thing is I have doing under local anesthesia. So the beautiful elevation, hardly any bleeding because being done under local anesthesia, and the scope doesn't get fogged frequently because of any use from the incision site. This is a very minimally edited video, almost like a full surgery I have shown. Without tearing, you elevate the flap and inferiorly also. Now I am going to the opposite side of the septum, that's on the right side, and elevating the flap on the right side. Always go in the correct plane, that's between the septal cartilage and the mucoperichondrium. Patients are very comfortable under local anesthesia with a good spinopatron block and IV sedation of dexmedetomidine and fentanyl. Patients are done under daycare procedure. Morning I operate and evening I discharge the patient. We don't pack the nasal cavity post-operatively. Gently elevate the flap on both the sides without tearing. Now I am elevating on the right side. Hardly any bleeding. You appreciate the quality of the field. No need for a suction elevator when you are doing under local anesthesia. So completely elevate the flap on either sides before going for the resection of the deviated cartilage, bony cartilage, and the cartilage, sorry, bony septum as well as the cartilaginous septum. Now I am finding the plane to dislocate the bony cartilaginous junction of the septum with the freest elevator. Some more dissection I am doing because I didn't get the plane. Now I have dislocated the bony cartilaginous junction. The deviated septal cartilage has been resected. First cut with the scissors, then with the Blacksley forceps I will take it out. That's a bony part of the deviated septum. Dissecting it out. Hardly any bleeding. You appreciate the quality of the field under local anesthesia. The septoplasty steps are little bit edited. Still there is a floor cartilage as well as the high superior cartilage which will be taken care, leaving an anterior strip of cartilage and superior strip of cartilage to prevent columnar retraction as well as the preventing the saddling. The floor spur cartilage has to be resected. With the freest elevator, I am dislocating from the maxillary crest. Gently dissecting the spur cartilage from the maxillary crest. You can preserve the spur cartilage and the septal cartilages for the tympanoplasty procedure by preserving in 70% alcohol. That is routine spirit, 70% and 30% distilled water. Now I am using the gouge to remove the bony spur. that has been removed. The high part of the septal cartilage was also resected, not shown in the video. Now we have got a good septal correction. You can see the choana middle terminate in full. Some secretions from the choana is being sucked out, but there is hardly any bleeding to suck. On the right side also, we have got a good field. You can see the middle terminate choana, everything clearly. Now gently lateralizing the inferior terminate for the better access to the spinopalatin area to do the post-nasal neurectomy. Gently with a heavy cartilage elevator, press so that the inferior terminate gets lateralized. This step is done on both the sides. Now I am doing the post-nasal neurectomy on the left side. The curved suction cautery, or I can use the Dr. Ahila's diathermy knife to make the incision for the PNN elevation. This is, remember, this is a very vascular area, so it bleeds much. So you have to do it under local anesthesia, or you have to use the cautery. Even though I don't prefer fire inside the nose, this is an important step. Now I am using the Freas elevator or the neurectomy elevator to elevate the mucosa. Incision should not go above the lower attachment of the middle terminate, otherwise you will encounter the spinopalatin artery, which may rupture and bleed. Now you can see the postnasal nerve coming into the view. That's a postnasal nerve, posterior superior nasal nerve, which will be cauterized. It is a very slender nerve. Sometimes it may branch into 2, 3, or sometimes it may be thick also. Usually it will be very slender. If the area is very bloody, you cannot identify. In that case, you have to blindly cauterize the area and come out. Now the nerve is cauterized and cut, and put the flap back. Checking whether the nerve is fully cut or not, then put the flap back. So I am repeating the step on the right side. For the incision area, I am using the cautery. Never go above the lower attachment of the middle terminate. Otherwise, you will go to the crista ethmodalis area and you will encounter the spinopalatin artery. Now with the neurectomy or the cartilage elevator, I am elevating the flap gently. Now you can see the nerve coming into view. It is very slender on the right side too. That's a nerve. That's a posterior superior nasal nerve. I am using the suction cartridge to take the blood. Then I will cauterize the nerve too. Superiorly, you can see the spinopelvic artery notching. Coagulated the nerve. Finally, I will be putting a quilting stitch for the septum to prevent septal hematoma formation and to keep the flaps together. I don't use septal splints or nasal pack post-operatively. The suturing is done with a 3O chromic haircut. I prefer with a cutting needle. Alternately, you can use a 3O Vicryl with a cutting needle. Patients are very comfortable under local anesthesia and hardly any bleeding throughout the surgery. Thank you for watching. Any queries, you please contact me in the above address. Thank you once again. We will see you in another video. Thank you.